think we can then start.
Yeah.
Dr. Rashmi has joined.
मैम अभी तक तो देख एक बार कॉल कर लेते हैं।
Hmm.
हाँ सर ज्वाइन करने बोल रहा है मैम। हाँ
So I think I'll just start with a small introduction till Dr. Rashmi joins. We are from Learn, and the starting the DRNB mock entrance mock was the brain of Dr. Prithviraj and Dr. Rashmi. And they wanted everyone to be very prepared before the exam, because usually what we see is though candidates clear, they don't really get those kind of numbers, and the deserving candidates usually don't get selected, and the ones who have just vaguely marked answers probably get selected. So we decided to do something for all of y'all, and as an introduction we put it very low price to get people under one roof initially. And it was purely Dr. Prithviraj who said that we would not do it as a profit making thing. We would mainly do it just for everybody to learn from the whole process. Okay. So, very active involvement in the group is there, if you all know, who all have registered. We have a separate group for that, and we have a very active involvement. And more you all involve, the better it will be for you all to that you all will get experience, because more you make mistakes, you will understand why the answer changed. Because it's not about just reading the answer, it is about using your concept to give the answer and then trying to analyze why is the correct answer not what you answered. So it is easy for me to read some MCQs and then read the answers, but then that does not give that productivity as in the exam as uh, kind of attempting and thinking, putting your thinking caps and deciding what you have to really do. Okay. So Dr. Prithviraj is here. He's from Delhi, Fortis Escorts. Uh, do you want to unmute and start your video as well?
yes sir.
So he's really, really put in a lot of effort into this in a very short period of time for the benefit of all. And Dr. Rashmi, has he joined?
Yes, ma'am. I have joined.
Sir.
Can you also start your video just for introduction? And all of you all who have joined on a Sunday evening, it would be great if you all can start your videos as well, because then the interaction will be better. You can start, ask questions. I mean, you all are the ones who are giving exam, right? So let's have some videos on, rather all on. That's great. At least one. So I think still, is everyone here, present here? At least you can write yes in the chat to know that you all are here and you all have just not switched on the Zoom meeting for the sake of it. Okay. Still, there is only one yes. Okay, so maybe there is a issue with switching on the videos. But it would be still great if you all can switch it on, because we can have then a better interaction and maybe discuss every question as we go forward, because it's not just, as I said, it's not just about knowing the answers, it's about knowing how the answer was reached. Because two options out of the four, two options are usually very close. Okay. So, Dr. Prithviraj, you want to say anything?
Ma'am, thank you for giving this platform. It was my brainchild, but the thing is that Madam supported throughout the time ki how to do and where to do. Madam gave a big platform for you all, and you all are very interactive in this group also. Whenever we put answers within 15 to 20 minutes, I get almost 15 to 16 answers over there, and most of them are very correct. and 60, at least every question has a 60% of correct marks. So when we are making this first mock question paper, I and Rashmi sir has a discussion to have a little bit harder. But after the exam, many of you told ki the first mock test is little harder. But we agree that first mock test is little harder, but it's good to have these hard questions before the exam, because 50 to 60% questions will be very easy, and that will not be a deciding score. So above, out of 100, during our time there was 100 questions, so out of that above 65 starts the rank, within 300 ki 250. So you have to get these hard questions right. So it's better to have these hard questions during this time than to have just before the exam. So all of you are doing very well, and you are in the closed group. Almost 49, 50 students have registered in the closed group. We are practicing daily 8 to 10 questions. We are trying to put answers every day. Yesterday's answers are only pending. Otherwise, we are posting the answers and the questions, guidelines, the reference. And the best thing is that 50 to 60% of the students are crossing the answers. Ki, sir, where from you get these answers? I know this answer. So it's very good that you are reading hard, and those who are in that close group are really reading very hard. Even one day I remember I went somewhere wrong between SIVCO2 and IGVO2. So two candidates messaged me, sir, how can you say ki IGVO2 is the blood from the lower limb? So it's very good ki you are looking into every words, you are looking into every questions, every options, and who are in the close group are really getting benefit out of it. Thank you, madam. That's all from my side. Ma'am, your mic is not.
Dr.
Yes,
Rashmi,
ma'am.
you want to say something before we start the answers?
Myself and Dr. Prithvi, we have prepared a lot of questions together and together from the experience as well as in the critical care books, as well as from the standard textbooks, which are which are really uh, uh, in the critical care from the critical care books, so which are useful for the prospect of the in their near future as well as for their entrance examinations. And the students are really answering great, and they have great knowledge, which is really encouraging. Wish them all the best for the near future and their entrance examinations. Ma'am, we can start the proceedings.
Yes, yes. Dr. Prithvi is sharing the PPT, right?
Yes, ma'am.
Please participate in this discussion. You can always, if you feel showing your video is a difficult task, you can always unmute and discuss.
Is my screen visible and audible, ma'am?
Yes, sir.
Okay. Okay. So let's start with the discussion of the mock test. So we all three are here to guide you through the journey to the NEET SS, critical care medicine, till November. 7th and 8th November. Hopefully the dates are already declared and we are only 2 months away from that journey. It's a very short time during this NEET SS because the last counseling has just ended in the July. So during our preparation, we do not have proper courses. Rather, we do not have any proper courses except only one book in our journey, and that all of the DRNBs during the first 3 batches will agree is this book, and that is the book of by Gunjan madam and Sandeep sir only. And we used to call it as a Bible of NEET SS exam. And this is not ki ma'am is here only. Everywhere when a student start preparation for FNB or NEET SS, there was only seniors used to say, you have this book and Bennington. These 2 books will enough to go through the NEET SS exam. But the days has evolved and there were a lot of coaching centers and good qualified intensivists are coming out with different coaching classes, and day by day the questions are becoming harder. During our time, we could not expect a question coming from a trial. But last session, the questions have come out from trial also, and it will take a shape of a NEET PG. Though it's very true that ultimately the cutoff will be lowered to 0 and you will get a seat. But getting a seat into NEET SS doesn't mean securing a good rank. So if you secure a good rank, you will get a better seat. And trust me, SS from a good institute, be it DM or DRNB, makes you more confident of for your future and of doing this kind of activities. Because you all know it is open secret what type of academics are held in which institute. So you have to be at least within 200, 250, max to max 300. Beyond 300, you are not going to secure such a very good seat. For DM, you have to be within 100 in good institute. So the motto of this course is to make you secure a good rank, not a rank which is sufficient to be in the 0 percentile. So we have planned 4 mock tests. 1 mini mock test is already over, and there are 3 more mock tests. The mini mock test is still available in the website. We have a group in the Telegram who have registered with 1000 till today. There are 51 students who have registered, and we are making sure that we post 8 to 10 MCQs. We haven't missed a single day except the day of the mock test. The answer of yesterday is still pending. It is more a pain to us that we cannot post the answers and we cannot make the commitment, because at a senior level, if we fail to commit, then we don't also expect commitment from your end. So we are posting daily 8 to 10 questions over there. So whosoever have not registered can register. I think you will be greatly benefited by this course. This course, what ma'am says, is beyond any business or beyond anything. It's just to make you educated and be a learned intensivist, which is a very important part. We are working at a ground level. Our teachers, sir, are working, madams are working at very higher level, administrative level, but we are working to make you, who are passing MD, anesthesia, emergency medicine, respiratory medicine, to make yourself little bit educated. There are a lot of questions where you get confused with the options, and we intentionally put those questions, like the questions of complete heart block. We put few days before in the group. Many of you said, why not, sir? It's a 2:1 second degree heart block. So these are the places we know where you will get hitched. So we put those questions intentionally. So you get bluffed before the exam, not in the exam directly. So coming directly to the test and discussion of our first mock test, I will be sharing the PPT, so I cannot see your video or whatever your expression. If you have any question, you can switch on your mic. You can ask directly on the mic. I will be happy to answer you. Even if you fail to ask the question on this session, we will be answering the questions in the closed group personally, I'm almost answering 24 hours a day. I go on to sleep answering 1 or 2 questions of you in the morning, 7 or 8 o'clock when I wake up. And then also I answer 1-2 questions. So you know, everybody who are interacting with me, that I am available all the time, especially for your exam questions. So you can ask me question after this session also. So coming to the first question. The first question was 45-year-old female diagnosed with breast cancer. Every word is important in the question. You should know that the question setter who is setting your question, I am only 6 to 8 years seniors, academically senior, may not be by age, but who are setting the questions, they are 25 to 30 years senior. So when they are using some word, each word is very important. So 45-year-old female diagnosed with breast cancer and right femur fracture. Both are giving evidence of some sort of thromboembolism can happen. Suddenly developed breathlessness and shifted to ICU. She was intubated and put on ventilator, having a blood pressure of 82/48 mm of Hg on a norepi of 0.1 microgram per kg per minute. She was suspected to have pulmonary thromboembolism. Investigation of choice in this patient. This was the first question of mine in Neet SS 2022. So this was the first question in the Neet SS 2022 of mine. So the concept of this question was to make you feel that this was an hemodynamically unstable pulmonary embolism. Normally, the investigation of choice is CTPA. The investigation, the golden investigation was pulmonary angio, which was not done nowadays. The investigation of choice is CTPA, but when it comes to an hemodynamically unstable patient, it is difficult to shift the patient to the CT scan room. So the investigation of choice in an hemodynamically unstable patient, the answer is transthoracic echocardiography. So this is a small 2-3 slides from the ESC guideline. If you want to read pulmonary embolism, the best guideline still possible is ESC 2019. Just to show you the obstructive shock definition is the systolic pressure less than 90 or vasopressor used to maintain greater than 90 along with the end organ perfusion. So this is the definition of the obstructive shock, which is very common with this pulmonary embolism, cardiac tamponade, and tension pneumothorax. So you have to know these things. What I will be discussing today is not only the question in the mock test, 2-3 questions ahead of those mock test. So you have to know the causes of obstructive shock, definition of obstructive shock. This is the classification of PE. The high risk PE is defined by the hemodynamic instability. Only the plus in the hemodynamic instability, as you see, my cursor is on, plus is the high risk category is have the hemodynamic instability. Once the hemodynamic instability is not there in a pulmonary embolism, then it is not a high risk PE. It becomes intermediate and low risk PE. So when you are asked you may not be said hemodynamically instability, you may be said the investigation of choice in an high risk pulmonary embolism. The answer will be transthoracic echocardiography because the patient is not stable. So this is what the guideline says in a suspected high risk PE as indicated by the presence of hemodynamically instability, bedside echocardiography or emergency CTPA depending on the availability and the circumstances. In our patient 82/48 on an inotrop of 0.1 microgram per kg per minute, it will come around to 6 to 7 ml per hour. It is impossible. So the clinical circumstances doesn't demand to the patient to be shifted to a CT room. The investigation of choice will be transthoracic echocardiography. And also you have to keep in mind in this patient, the treatment of choice is IV anticoagulation and thrombolysis to be done in the hemodynamically unstable high risk pulmonary embolism. So high risk pulmonary embolism, anticoagulation plus thrombolysis. So if you also see by this chart, hemodynamically unstable patient suspected P, the investigation is bedside transthoracic echocardiography. So it's clear, hemodynamically unstable, transthoracic echocardiography, hemodynamically stable, CTPA, golden or the investigation of choice is pulmonary angiography, which is not done nowadays for all pulmonary embolism patients. So coming to the second question, the second question was the TAPC is an indicator of. This time only this question has come. The TAPC is an indicator of right ventricular systolic dysfunction. So we measure TAPC to see whether the right ventricular systolic function is right or not. So what do you mean by the TAPC? TAPC is tricuspid annular plane systolic excursion. So the name explained everything. This is a tricuspid valve which is between the RA and RV. This is the annular plane systolic excursion. So that is measured by the M mode, and TAPC less than 17 mm is suggestive of RV systolic dysfunction. So it is measured from this baseline up to the peak. So for our level, for your level, measured by M mode, full form, what does it signifies? RV systolic dysfunction, RV systolic dysfunction, and it is measured from this baseline to the peak, and 17 mm, less than 17 mm is an indicator of RV systolic dysfunction. Coming to the next question, therapeutic dose of fondaparinux in a 120 kg weight patients. The intention of giving my question was to read the anticoagulant properly and also to have a concept that the fondaparinux dose doesn't change above 100 kg of weight. So coming to the answer is 10 mg in the patient of a therapeutic dose of fondaparinux. So if we are saying therapeutic dose, so there should be some prophylactic dose. If we are mentioning the 120 kg weight in the question, so there should be something according to the weight also. So this is a small discussion about the fondaparinux. What I want you to remember is the fondaparinux is given subcutaneously. Number one. Number two, it binds to antithrombin 3. Just follow my cursor. Number four, the mechanism of action is it works by binding to antithrombin 3 and inhibiting factor 10A. So bioavailability 100%, subcutaneously given, 94% bound to antithrombin 3, inhibit factors 10A. Half-life is 17 to 21 hours, may not be asked, but you can remember GFR less than 30 is a contraindication of using fondaparinux. So it is excreted through urine. So GFR less than 30 ml per minute is a contraindication for using fondaparinux. Coming to the indication, it is used in the heparin-induced thrombocytopenia. It is used in the DVT prophylaxis. What is the dose in the DVT prophylaxis? 2.5 mg subcutaneous OD. It is used therapeutically in two conditions. One, pulmonary embolism. Number two, it is used mainly in two conditions. One is pulmonary embolism and another is non-ST elevated MI. Remember, fondaparinux is contraindicated in ST elevated myocardial infarction. So it's a very important MCQ for you. Ki fondaparinux is contraindicated in ST elevated myocardial infarction. Non-ST elevated myocardial infarction patient with no urgent plan for cardiac catheterization. If the patient is taken for an urgent cardiac catheterization in NSTEMI also, then also fondaparinux should not be given because it has a long half-life. So we should not be given in STEMI, we should not be given in NSTEMI with a plan of an urgent cardiac catheterization. The dose, and this part was your question, above 100 kg, the dose remains 10 mg OD. 50 to 100, 7.5, less than 55, and profile axis is 2.5. You cannot make mistakes in this question. These are the questions also from your MD anesthesia, medicine, pulmo, and emergency medicine background. So these are the basic question, anticoagulant you should know. Our aim of the exam is to pin you and to pick you from sleep. Read this topic. So don't go by the questions only. Whenever we are posting a topic, try to cover that topic also along with that question. So what I have written here, read also unfractionated heparin, LMWH, NOACs, and DOACs. The question 4 was, which of the following is not a window for diagnosing shock? There was 4 option and the 4 option seems to be correct. Urine output less than 0.5 ml per kg per hour, altered sensorium, cold and clammy skin. These 3 are the windows of hypoperfusion in diagnosing a shock. SBP less than 90 mm of Hg is not a criteria for diagnosing a shock. So answer is SBP less than 90 mm of Hg. So what is the definition of shock? Shock is defined by the systemic manifestation of low tissue perfusion, which is inadequate to meet the normal cellular respiration. There is no word of BP in the definition of shock. It is manifested clinically by 3 windows. You can see in the pictures, this was a very beautiful picture from a journal from which gave me the idea of this question. The 1 second just. So this day.
Whole of Bengal. Okay.
পুরো খালি
তোমরা গেলে না? না, এরপর শরীর বললো হাতে করে আনা যাবে না।
Extremely sorry. I'm audible, sir?
Yeah, you're audible.
Prithvi audible.
Okay.
Continue.
Okay.
I think you are in shock.
नहीं sir, ये slides are not moving.
That question was in some shock, right? I think.
हाँ
It's lactates. You are saying something lactates.
हाँ नहीं sir. So back to our sorry for this technical interruption. So there was 3 window in the shock basically, which is the altered mentation, oliguria, and the cold and clammy skin. And the lactate greater than 2 is also part of the shock, but the arterial hypotension, as you can see, is not a part of the definition of the shock. It may be there, it may not be there. In many trials, they have used of these SBP less than 90 as the criteria, but if you go by the definition of the shock, SBP less than 90 is not a criteria for diagnosing a shock. There is a term known as cryptic shock, where the SBP may not be less than 90, though the patient may be in a diagnosis of a shock. So less than 90 was not the criteria. Now fear and CASA protocol in POCUS is used in. This is little bit a hard question for you. This is the answer is the cardiac arrest, but I want you to know the name of this protocol used in the point of care ultrasound. POCUS, if you are not knowing the full form, is the point of care ultrasound. Here, this fear and CASA protocol are used in the cardiac arrest. So these are the protocol which are normally used in the cardiac arrest. You can see you have to remember these two names, fear, CASA. There may be a question from the Sesame protocol, sequential echocardiographic scanning assessing mechanism of shock. And the most important protocols which you should remember is a rush protocol, is a rapid ultrasound for the shock and hypotension. So if the question comes, what you see in the rush protocol, then you have to remember as high map, heart, IVC, Morrison's, aorta, and pulmonary window. These will exclude the cause of the shock. So rush protocol, you should remember. CASA and fear is a little hard question, but rush protocol for shock and hypotension, you should remember. For excluding shock, heart, IVC, Morrison's pouch, aorta, and pulmonary window. These 5 windows you have to see. We known as the mnemonic by high map. Another is the false protocol. False protocol is giving fluid guided by the lung ultrasound. So there also we give fluid guided by the fluid administration, guided by the lung ultrasound, limited by lung ultrasound. So this is the protocol. It is not the place to explain you this protocol, but you should know the name of this protocol. Rush protocol for diagnosis of shock. False protocol for giving fluid in shock. CASA protocol is for cardiac arrest. Fear, feel, CASA, cause. These top four are for cardiac arrest. Sesame protocol is for diagnosing the mechanism of shock. So these 4 chart you should remember for your exam. Next question was class 2 hemorrhagic shock is defined by. The answer was possible use of blood products, because base excess -6 to -10 goes in the category of class 3. Decrease in SBP or systolic blood pressure occurs in the class 3 hemorrhagic shock. Decrease in heart rate or change in heart rate also occur in the class 3 hemorrhagic shock, not decrease, the increase in heart rate. So as you can see that the heart rate mainly changes from the class 3. Blood pressure remains stable, still the patient lose 30% of the blood. So this is very important, that the blood pressure is not an indicator of giving fluid or resuscitation in a patient with hemorrhagic shock. This is the takeaway message. And the pulse pressure is the earliest indicator to change apart from the base deficit. that the pulse pressure decreases in the class 2 hemorrhagic shock, but the heart rate goes high mainly from the class 3, maybe in class 2, but mainly in the class 3. But the option was decrease in heart rate, so it cannot be an answer. SBP decrease from the class 3, and all the changes happens from the class 3. Only the pulse pressure changes in class 2. What happens to the pulse pressure in the hemorrhagic shock? The systolic BP comes down due to the decrease of cardiac output. The diastolic BP goes up due to the vasoconstriction. So the pulse pressure becomes narrow. So the pulse pressure decreases in the class 2 hemorrhagic shock, and other parameters changes after the patient lose at least 30% of the blood volume or class 3 hemorrhagic shock. Lethal diamond in trauma include all except. The answer is hyperkalemia. The lethal. So what is the lethal diamond? So let's go to this explanation. The triad, previously it was a triad of hypothermia, acidosis, and coagulopathy. The patient was in coagulopathy. We used to resuscitate the patient with blood products. Patient goes into the hypothermia. That cause acidosis, that again cause coagulopathy. So this was known as the triad. So to this triad added one component more is the hypocalcemia. So all the options were the part of the lethal diamond, but hyperkalemia is not the part of lethal diamond. I gave the options because I know that when we are giving so much of blood products, hyperkalemia may come into your mind, that after giving so much of blood product, the patient may land into increased potassium along with an AKI, but hyperkalemia is not a part of the lethal diamond. Which of the following trial is not related to the use of colloid? 6S, chest, and bicep. These three trials put a pin into the coffin of colloid, and the colloid mainly this starch. We have stopped using this starch because it causes more amount of major adverse kidney event or which we will be coming in the coming slide. But the salt ED was not related to the crystal colloid. It is related to the crystalloid. It is very unfortunate for your standard. It is a higher question, but trust me, for the last year also, Oscar trial has come in the exam. 1 or 2 trial has come in the previous years also. As the standard is going high, you may have this question. So these are the basic start of the septic shock. So you should remember 6S, chest, and bicep. These 4 are the trial for the colloid. You see, chest, 6S, bicep are the trial against the colloid of using starch. And SAFE and albios is for albumin. And crystal and Christmas are the 2 trial which supports the colloid, but the chest, 6S, and bicep goes against the colloid. And so the septic shock guideline now strongly recommend not to use starch and suggest not to use gelatin. Starch, strong recommendation. Gelatin, suggestion. So we should be avoiding colloid in patient with septic shock to avoid major adverse kidney events. So you should remember, main thing is the kidney injury, and next another also is the coagulopathy. So we should be avoiding colloid. These are the trials for the crystalloids in the septic shock patient. Split, salt ED, SMART, basic, and plus. But what you should remember that the 2021 septic shock guideline has recommended for not grade 1, but has suggested for using balanced crystalloid in the resuscitation of the septic shock patient. What triggered that suggestion is the SMART trial in 2018 that goes in favor of the balanced crystalloid in septic shock. But as soon as the guideline is published, the basic and the plus trial, these 2 trial goes against the use of have not proved any benefit of using balanced crystalloid. So you should be remembering this name. I think the name at your position is enough, which is supporting the balanced crystalloid, which is not supporting the balanced crystalloid. not the limitations, not the result, anything. So support split basic plus against salt ED and smart trial. For you, it is more than enough. Will fetch you rank in top 50. I can assure you, because at your level, I was not even heard of this term. So questions are coming. So we have put into here. True statement about critical illness related corticosteroid insufficiency. So this question is very important. There is a term called critical illness related corticosteroid insufficiency. That doesn't mean that the corticosteroid is not getting secreted. This word means that the corticosteroid which is getting secreted is not sufficient to make up the stress response of critical illness. So this is basically a relative deficiency of corticosteroid. So this is known as critical illness related corticosteroid insufficiency. If you go by the 4 options, CIRCI or critical illness related corticosteroid insufficiency can be present with normal cortisol level and normal delta cortisol response to ACTH. So it can be present. What do I mean by this statement? That even if the cortisol level is normal, even if the delta cortisol level is greater than 9 in response to the high dose ACTH stimulation, then also CIRCI can be present, because CIRCI can also be present due to the defect in the receptor level. So this was the right answer, number A. Delta cortisol response after cosintropin injection is the method of choice. It was method of choice before 2023 or 22 when the guideline of steroid or CIRCI came, the latest guideline. In the previous guideline, rise of greater than 9 was the method of choice to establish CIRCI. But now the answer of diagnosis of CIRCI is only and only the clinical diagnosis. Delta cortisol response is not the method of choice, because it has been said that maybe the patient has exhausted his whole cortisol response before you get tested. So before the patient get tested. So it may be the patient is at the peak of its cortisol response and you are trying to stimulate the patient with a cosintropin injection and you are trying to test. So delta cortisol is only a test of reserve. It is not the test of response. So it has been eliminated in the recent guideline. The method of choice is now only and only clinical diagnosis. Pre-cortisol recommendation is not done, because cortisol is bound to albumin. May it seems that the free cortisol is will be a better choice to investigate, but it is very cumbersome process to diagnose free cortisol or salivary cortisol. So free cortisol is not recommended still now for diagnosis of this corticosteroid insufficiency in critically ill patient. CIRCI is present in almost 60% of the patient with septic shock, not in 25% of the patient in septic shock. So the takeaway message from here is CIRCI can be present with a normal cortisol and a normal delta response. CIRCI can be present because it can be present at the receptor level. Delta cortisol is no more a choice because it is a test of reserve, not a test of response. Free cortisol is cumbersome to measure. Maybe it can give a better impression than the total cortisol, but we can adjust it with the level of albumin. There are articles with that, but free cortisol is not recommended for diagnosis. CIRCI total cortisol, even if it is done, what now the guideline is nothing to be measured. If the patient is hypotensive and the patient is requiring NOREP more than 0.5 microgram per kg per minute, start steroid at a dose of septic shock 50 mg QID or a total dose of 200 mg, not more than 400 mg. So these are all the higher knowledge, but what you should know is the 4 options is enough for you. There are definition, what I have discussed for the CIRCI, it's a clinical diagnosis, no more a diagnosis for exclusion. You can see in this diagram, that GC resistance, matlab the glucocorticoid is resistant at the tissue level. So even if it is excreting out, even if it is responding properly with the high level ACTH hormone, even the patient may have a corticosteroid insufficiency in the critical illness patient because of the GC resistance at the cellular level. So we should not exclude this as the cause of corticosteroid insufficiency also in the patient with septic shock. So these are the mechanism. The last mechanism targets tissue resistance to cortisol. So this is also the most important mechanism. It may be altered synthesis, it may be altered synthesis from the adrenal, it may be altered synthesis of ACTH, it may be metabolism of cortisol. Even if all those three remain right or okay, the fourth cause may be the tissue resistance or the resistance as the at the cellular level. Which of the following antibiotic acts on the cell wall? So this is a important question for your level. So which of the, so we should remember which of the following antibiotic acts on the cell membrane, acts on the cell wall, acts on the protein inhibition or the protein synthesis mechanism. So the answer here is the fosfomycin, which acts on the cell wall. Confusion would have been with polymyxin or daptomycin. These two acts at the cell membrane level. Clindamycin acts at the protein synthesis level. So this is a chart where you can see the at the membrane level, the drugs acting at the poly B and daptomycin. These charts you should memorize thoroughly. Proteinase, aminoglycoside, tetracycline, TG-cycline. 50S are chloramphenicol, clindamycin, linezolid, macrolide, streptogramine. So these are the inhibitors of protein. Cell wall is mainly beta lactams, along with are the glycopeptide. Which are the glycopeptide? Vancomycin and teicoplanin or targoside. And nucleic acid synthesis, the question you should remember, rifampicin or the anti-TB drugs, there are in the options of nucleic acid synthesis, interference with the nucleic acid synthesis, and the metabolic pathway folate is the sulfonamide and trimethoprim. So you should remember the mechanism of action of these antibiotic from this chart. Which of the following is non-lactose fermenter? My question of Neet SS 2022, I did wrong. You should not do it wrong. So the answer here is Salmonella. Klebsiella, E. coli, Salmonella, and Enterobacter. The answer is Salmonella. So you should be knowing this chart of gram-negative bacteria, lactose fermenter, lactose non-fermenter. Lactose fermenter, most common are the E. coli and the Klebsiella pneumoniae. Lactose non-fermenter are the Pseudomonas, Vibrio, Aeromonas, Burkholderia, Acinetobacter, Stenotrophomonas. So all bad bacteria, all headaches of ICUs belong to the lactose non-fermenter. We call in the micro, if the micro people says that the bacteria is not, the GNB is non-lactose fermenter, we change our antibiotic because the normal antibiotic doesn't cover these headache bacteria which cause real headache for the intensivist. So the non-lactose fermenter have all these names: Pseudomonas, Burkholderia, Acinetobacter, Stenotrophomonas, Protea, Salmonella, Shigella, whatever notorious bacteria can be is in the category of non-lactose fermenter. This is of the gram positive. We are not discussing. Maybe in the second, third test, we will be having question from here. So read this also: catalase positive, catalase negative. Remember that the catalase negative is Streptococcus and catalase positive is Staphylococcus. And but the question, the examiners are intelligent to trap you. They ask the question, what is Enterococcus? So remember, Enterococcus is the group D Streptococcus. It is nothing but the Streptococcus if catalase negative. So be it be a Officium, be it be a Fecalis, it will be catalase negative. So this is a famous MCQ question, often comes in the quiz in our conferences. Then the Enterococcus faecium is positive, Fecalis is negative. Whatever be the Enterococcus, it belongs to the group of Streptococcus. So it is catalase negative, negative, and negative. Positive is staph. On staph, there is coagulase positive and coagulase negative. Positives are our MRSA and MSSA. negatives are the most commonly commensals of the skin. So these charts you should remember thoroughly. Which of the following antibiotic is a bactericidal antibiotic? The answer here is the amikacin. So here the linezolid, clarithromycin, doxycycline is not a bactericidal. So how to remember this? So this is a chart basically. If you see what is written in the below, the red ones are the bactericidal, the blue ones are the bacteriostatic. Remember this small formula which I have been taught during the pharma days. Antibiotic acting on the cell wall are bactericidal. Antibiotic acting on the protein synthesis machinery are bacteriostatic. The exception is only aminoglycoside. Aminoglycosides are the bacteria which inhibits the protein synthesis but is an bactericidal. So you can see in the sidal, number 1, cell wall, number 3, cell wall. These are with the RNA and DNA. Streptogramins we do not use normally. Number last is the cell membrane. So cell wall, cell membrane, bactericidal. Rule is fixed. Protein machinery, bacteriostatic. Exception is aminoglycoside. So that's the reason why I gave the question, because the aminoglycoside, amikacin belongs to the aminoglycoside. So for the aminoglycoside, the bactericidal antibiotic, so for aminoglycoside belongs to the bactericidal antibiotic. So the low hepatic extraction drug is affected by. The question itself says that it is a low hepatic extraction. So it is not extracted in high amount in the liver. So the blood flow will not affect these drugs. So the drug will be affected by the induction of the hepatic enzymes. So if it would have been extracted more in the hepatic or the liver, so it would have been affected by the blood flow. If it not been extracted in the liver much, if it is a low hepatic extraction, so it will be affected by the induction of hepatic enzymes. So these are in details. Pulmonary vascular resistance is calculated by. This question is also the question of my NEET SS 2022. So the answer in this is mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by cardiac output into 80.
Hello.
This is the answer for calculating pulmonary vascular resistance. If you are
ওদিক থেকে
asked,
দেখা যাবে কিন্তু কেউ থাকলে
if you are been
মহিলা
asked,
ঘুরছিল একটু আগে
if you have been asked about the systemic vascular resistance, then the option would have been option C,
চলো
right? So systemic vascular resistance, the option would have been option C. If it had been option A, then it is the pulmonary vascular resistance. So how to remember this? So PCWP is basically the left atrium pressure, right? PCWP is normally reflects the left atrium pressure. The pulmonary artery pressure.
হ্যাঁ বললাম তো হুম সাধারণত তো কাজগুলো তাই হয় যেখানে লাইট বেশি সেদিকে দেখা যায়
You people can mute. There is a lot of disturbances.
So PVR. So how to remember this? That PAP comes out from the RV, and from the RV, the blood goes into, by passing the pulmonary circulation, the blood goes into LA. So PAP marks, it deals with the RV, and PCWP deals with the LA. So the blood growing from RV via the pulmonary circulation to LA. So pulmonary vascular resistance will be marked by two parameters: PAP, which is depending on the right ventricle, and the PCWP is depending on the left atrium, and the pulmonary vasculature is connecting these two. So the pulmonary vascular resistance formula will be mean PAP minus PCWP by cardiac output into 80. But when it comes to the systemic vascular resistance, the blood comes out from the LV. LV का marker क्या है? What is the marker of LV? MAP. It is coming to the RA. What is the marker of RA? It is CVP. So MAP minus CVP divided by cardiac output into 80 gives you the value of SBR or systemic vascular resistance. By this we can remember, and if you have another option to remember, you can remember by this, but these are the formulas you should remember for your final exam. These are the normal values we should remember for the final exam, because questions may come giving these values. It will be not be said that the SVR is increased or decreased. So you have to remember these values for solving clinical based questions in your exam. So this is what I have discussed now, that MAP is the marker of LV and CVP is the marker of RA. So the SVR lies between these through which the blood needs to travel. So the formula is MAP minus CVP divided by cardiac output into 80. PVR is PAP minus PCWP or POP by CO2 into 80. So this we can discuss in some other tests. These are also the potential questions we will be discussing in the subsequent tests. This is the question of my Neet SS 2022. We will be discussing in the subsequent test. Remember POP assumption. This is very important for you to remember. All four becomes equal when the mitral valve is normal, compliance is unchanged, geometry is normal, catheter is positions properly. We will be discussing in details in next test. We will be giving questions from these equations because it was the question for in my Neet SS 2022. In a ARDS patient, P plat is 30, PP is 10, tidal volume is 400 ml. We have discussed in our close group, and I have seen 80% of the students have given right answer. For measuring dynamic compliance, we need peak inspiratory pressure. P plat is for static compliance measurement. So the answer is the inadequate information. All of you almost have given the right answer, and you people are doing extremely well in the group. So I will be skipping this question, not going into much detail. So these are the definition of dynamic compliance, static compliance. Dynamic compliance, the denominator will have peak pressure. Static compliance, the denominator will have the plateau pressure. Rest, everything will be same. You must expect one question from this formula. It comes again and again in the Neet SS and NESS. Don't get confused between the dynamic and the static compliance. The only difference is the peak pressure and the plateau pressure. ROC score is denoted by, we all know, SpO2 by FiO2 ratio divided by RR. Now the question is where it is used. It is used in the HFNC or high flow nasal cannula. So this is the formula of ROX index. You should not do this type of question wrong, because these are not the rank deciding question. These are the eliminating question. If you do this type of question wrong, then you are eliminated out of the competition. So ROX index you cannot do wrong. So it is the respiratory rate and oxygenation ratio. So SpO2 by FiO2 divided by respiratory rate give you the ROX index. Another score which may come in your exam is the Hackett score. The heart rate, acidosis, consciousness level, oxygenation, and the respiratory rate. These 5 variables belongs to the Hackett score. So you should remember there is one score also which is also used in HFNC, but most commonly used in NIV is the Hackett score, which has heart rate, acidosis, consciousness level, oxygenation, and respiratory rate as the component. These are the cutoff of ROC score. You can take the screenshot. You should only and only remember the red numbers: 2 hour, 6 hour, and 12 hour, 2.85, 3.47, and 3.85. Not at all the whole table. Only the red points you should remember, and rest you can ignore at this level. But these are the very common and the scoring question at your DRNB theory exams. But at your level, only the red boxes if you want to remember at all. Otherwise, the previous slide will be sufficient for your Neet SS exam. Modified Marshall score include all except the answer was GCS. This was the NESS question in 2022. So modified, because I gave exam in 2022, I remember almost most of the question in 2022. Sir was 1 year senior to me. Sir gave exam in 2021. So modified Marshall score include all except GCS. So where is this score used? This score is used to diagnose the organ dysfunction in acute, severe or moderately severe pancreatitis. So this is the score which has the three component: respiratory component, renal component and the cardiovascular component. The respiratory component greater than 400, 301 to 400 like the PF ratio, and the renal is the creatinine and the cardiovascular is systemic blood pressure. Remember, wherever you have systemic blood pressure in the scoring system, there is a potential to have a MCQ to trap you with MAP. So they may give MAP in the modified Marshall scoring system and you may think that the BP is there, so MAP will be there. So no, here it is SBP, somewhere it is MAP, and somewhere it is SBP. There is a difference between Q SOFA and SOFA. So you should remember all these tricks which is happening in the question. And this is used in the severe pancreatitis. So these are the some slide about the pancreatitis. We will be discussing in some other tests. So this was the question given by me in the closed group. This was also asked in 2022 Neet SS. Determinant based classification of acute pancreatitis. This is almost same as the revised Atlanta classification. Only change is the critical category. If the organ failure is there and there is an infectious pancreatic complication which is proven by a culture positive pancreatic collection, then this goes to a category of critical. At my exam, I thought that this was to trap me, ki critical cannot be an option. And I saw most of you also are trapped in that. 80% gave the answer of 80% gave the answer of severe, but the option was critical. If it is culture positive plus persistent organ failure, and in the question it was mentioned determinants best classification of acute pancreatitis. I have not known those terms during that time after post-MD anesthesia. So you should be knowing that the critical is when the culture is positive and there is an organ failure. Mechanism of HFNO is mainly. Please make your mic mute so that we can continue. Or if the moderator can also. So mechanism of HFNO is the decrease of the dead space ventilation. So the decrease of the dead space ventilation is the main mechanism of the HFNO by the high flow generated by this machine. So what is alveolar ventilation? The minute ventilation minus the dead space is equal to the alveolar ventilation. So this is the reason why I have given this question, because you should be very clear about the concept of alveolar ventilation, which is nothing but minute ventilation minus the dead space. As the dead space decreases, the alveolar ventilation increases by HFNO. So the answer is increases alveolar ventilation. So this is the chart by which the HFNO acts. You can see the video later on. The recorded version will be in your login ID who have registered this course. So that this recorded video will be there of every test. So you can see later on how the HFNO work. If you cannot understand, you ask me question individually, because the time is short. I am going little bit faster. So these are the recommendation. The most strong recommendation of HFNO or HFNC is the hypoxic respiratory failure or the type 1 respiratory failure. When the name of HFNC comes, you should also remember one trial in your mind, that is the Florally trial. The Florally trial is used for HFNC in ARDS patient. Proven benefit for the moderate and severe ARDS, but trust me, you don't need to go by the trial. But if it is, I mean, asked only at your level, it can be asked. Florally trial is related to HFNC in ARDS. Likelihood ratio is defined by, the answer here will be sensitivity by 100 minus specificity. Why? So you should remember this formula. Apart from the sensitivity, specificity, positive predictive value, negative predictive value, the harder question in your statistics can be likelihood ratio. The positive likelihood ratio and the negative likelihood ratio, the formula goes like this. It is the sensitivity divided by 1 minus specificity. Actually, it is the ratio that how much of the patients will be tested positive who truly have the disease. So the true positive ratio, that is sensitivity, right? And it will test positive who doesn't have the disease. So specificity is, it will test negative who doesn't have the disease. So 1 minus specificity will be who will test positive who doesn't have the disease. So likelihood ratio is basically, positive likelihood ratio is basically the ratio between who will test positive who have the disease, that is sensitivity, who will test positive who doesn't have the disease, that is 1 minus specificity. So you remember this, go to the Google, read the concept. If you cannot understand this, so you text me, I will make you understand individually. But you should be remembering this formula for your exam, because it is a very favorite question for the NESS exam. A screening test is applied to 300 patients with and without disease. Out of 100 who have disease, 60 test positive. So who have disease, 60 test positive means these 60 are true positive, right? Of 200 without disease, only 20 test positive. So this is false positive. So what is positive predictive value? True positive divided by true positive plus false positive. What does it mean? Mean that how much the test is giving positive results to those people, out of which how much is actually truly positive. So truly positive is 60 divided by true positive plus false positive. 60 plus 20, 80. So answer is 0.75. So these are the formula you cannot make wrong in exam. This you can expect one question from these 4 formula in your exam. Sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratio, positive likelihood ratio, negative likelihood ratio. These 6 formula you should be memorizing from your for your Neet SS exam. So for our question, the answer was 0.75. 60 divided by 80, 0.75. Levosimendan and milrinone. These 2 questions are asked again and again in your exam, because these are like little bit a fancy drug and belongs to the group of ionodilator, right? What do you mean by ionodilator? The drug have the property of ionotropy and the drug have the property of vasodilator. So the contractility is increased and the afterload is decreased. So the heart gets it's become more easier for the heart to act, and it is mostly used in the cardiogenic shock or the right ventricular failure. So at our level, we should be knowing the mechanism of action. So levosimendan is a calcium sensitizing. I agree, but it doesn't sensitize to troponin T. You should remember troponin C, C for calcium. So the calcium sensitization of troponin C is the function of levosimendan. Next, what does it does to the vascular smooth muscle? For the vascular smooth muscle, there is nothing calcium sensitization. What it does, it opens the ATP dependent potassium channels. As it opens the ATP dependent potassium channels, there is a vasodilatation. It has nothing to do with the adrenergic receptor activation. So lastly, the C option remains the right, that it acts in the mitochondrial potassium channel activation and thus act as a cardioprotector. So if you have given these options, so be very careful. Calcium sensitization of troponin C is the answer, but we don't have that option in your in this question. So the answer will be mitochondrial potassium channel activation. There are three functions. One, inotropy by calcium sensitization of troponin C. Second, vasodilatation. ATP dependent potassium channel opening or activation in vascular smooth muscle cells. And third, ATP dependent potassium channel activation in mitochondria causing cardioprotection. So the option C, this mechanism causes cardioprotection. So this is the right answer in this question. These are the three mechanisms of action of levosimendan. Remember, troponin C is for calcium. C is for calcium. So we should not mark troponin T as the option. And ATP dependent potassium channels, it opens or activate, doesn't inhibit. It may seem that it is getting vasodilated, so something is inhibited. The concept is wrong. So it is inhibited, as the insulin is also secreted by the inhibition of the activation of this ATP dependent potassium channel in the pancreas. Like that also, in the vasodilatation, the ATP channels are activated in the vascular smooth muscle. And the last mechanism of action is cardioprotection. So this is also the mechanism of action of milrinone. We will be discussing in the next test. Durand maneuver is for air embolism. It is straight and forward question. So this is a mechanism by which we make the patient left side lateral decubitus and make the patient Trendelenburg so that the air comes out of the heart. So the left lateral position made in the pulmonary air embolism is a Durand maneuver. So this may be a question in your exam, and you should also be reading the treatment or management of air embolism. Otis equation, today morning somebody was asking, sir, what to read about the advanced mode of ventilation. If you are able to read, it's fine, or else we will be covering in our daily MCQ, because it's very hard for us also in the advanced mode of mechanical ventilation. So Otis equation is used in the adaptive support ventilation. Just remember these names for your exam. These are the harder questions. So this is all the concept. The ball should be at the center. In this mode, the respiratory rate, tidal volumes are not set. Only the minute volume is set, and the weight of the patient is set, and then the ventilator by his intelligence determine the tidal volume and the respiratory rate to keep this ball at this middle by adjusting the pressures, respiratory rate. Ultimate aim is to minimize the work of breathing. So if the question comes, ASB is meant for what? ASB is meant to minimize the work of breathing, works by the equation, Otis equation. These three questions finishes your discussion about ASB before the NEET SS. Once you qualified the NEET SS, you can have a thesis on ASB, but before that, stop reading this advanced mode. Otis equation, minimize work of breathing, and if this graph is given to you where the ball should be placed, this ball should be placed at the intersection of this axis at this point. So the aim of the ventilator is to be at this point to minimize the work of breathing. What is this? The identify the procedure. You can see the defibrillator pad being placed anterolaterally and anteroposteriorly together. So this is basically the double sequential defibrillation for refractory VT and VF. This question may come for you because it's an emerging concept. So what is refractory VT or VF? The definition, if it doesn't respond to the three shocks, so it becomes a refractory VT and VF. So the double sequential defibrillation is coming as the advanced treatment of choice for this ventricular tachycardia storm or the refractory VT and VF. Then if there is no scope of using two defibrillators at a time, then one defibrillator can be changed from anterolateral to the anteroposterior. So as you can see in this diagram, in the last, this is a double sequential defibrillation. So here two ventilators are used. One is used anterolateral, one is used anteroposterior. If there is no scope of two ventilators, if only one ventilator is there, then one time you give anterolateral, one time you give anteroposterior. So this is known as vector change defibrillation for refractory VTVF. So these two can be an option for VTVF, the best being the double sequential external defibrillation for refractory VTVF. So remember this classical picture which can come in your exam, double sequential external defibrillation for refractory VTVF. This was the CT identifying. It is a midline mass which has enhanced after giving the contrast, causing chronic symptoms in the patient. So this is basically meningioma. So the abnormality in this CT was the meningioma. This was, I had copied this from this website, Radiopedia, that the CT brain meningioma, this is a post-contrast enhancement of a large mass from the contact with the meningeal surface of the falx. So this line is the falx. So that it, as it is in the contact with this meninges, so it is likely to be meningioma. Negative anion gap. So we all read positive anion gap. So the negative anion gap can be seen mainly in the presence of cation, which is replacing. Basically, the anion gap is sodium minus chloride plus bicarb. So if the sodium comes down by any way, the gap becomes negative. If the chloride or bicarb come down by any way, the gap becomes high anion gap. So to become the gap negative, the sodium should come down. In severe hypoalbuminemia, the anion gap become negative, and if we correct that gap with the correction of albumin with 2.5 for each one decrease from the 4 or the normal value of albumin, the correction factor is 2.5. If we correct the anion gap, then it becomes normal. So the severe hypoalbuminemia, the anion gap becomes negative. For lithium poisoning, the lithium is a cation which replaces sodium in the serum. So you cannot get an electric shock by touching a body. If a lithium is going in abundant number, the cation will be replaced. So some other cation will be replaced. So the cation replaced will be sodium. So the sodium will come down. So there will be a hyponatremia. So if you are calculating the anion gap at that point, then also you will get a negative anion gap. In the hyperproteinemia or lipidemia, you will get a pseudo hyponatremia. So these questions, you may not get this type of question directly. You have to use your brain little bit. The hyperproteinemia or lipidemia causes pseudo hyponatremia, right? So pseudo hyponatremia you have read, or hypertonic hyponatremia. So that will come down with the sodium and the gap will become eventually negative. So if you are getting a low anion gap, first repeat the ABG. It may be a testing error. Correct for albumin. Even if it is low anion gap persists, then think that there is some cation other than sodium which is replacing it in the serum. That is why the sodium level has come down. So suspect lithium toxicity, suspect lithium overdose. If it is also not there, then go for the hyperparaproteinemia or proteinemia or hyperlipidemia. If it is also not there, then go for the overestimation of the chloride. There are some that in case of salicylate poisoning, in some machines or some method of testing, the chloride can be overestimated. In that cases also you may get a negative anion gap. Hyperthermia, dilated pupil, sweaty, hyperreflexia with clonus. Diagnosis is, remember, if it is hyperthermia with clonus with hyperreflexia, the answer is serotonin syndrome. If it is rigidity, hyporeflexia, hyperthermia, then the answer is neuroleptic malignant syndrome, right? So these are the differential for hyperthermia along with altered mental status. So the differential point is basically the reflexes, the Brady reflex in case of neuroleptic malignant, because this is antipsychotic drug. These are the dopamine antagonists. So in the dopamine antagonist, you remember what happens in the Parkinsonism when the dopamine is antagonized. So there is a bradyreflexia. Like that, you remember in the neuroleptic malignant syndrome, the antipsychotics are the dopamine antagonist. So it also causes bradyreflexia and rigidity. But the serotonin syndrome will cause rigidity, but the reflexes will be hyper and there will be clonus. So these are the charts we can read later on. Tumor lysis syndrome most commonly occur with AML, ALL, CLL. The cells where have a high turnover during the chemoradiotherapy and before or after. You have to remember the electrolyte disbalance. There may be a hyperphosphatemia, hypermagnesemia, hyperkalemia, but only hypo is calcemia because it binds with the hyperphosphatemia and the phosphate levels become high and it binds with the phosphate and the calcium goes down. So the hypercalcemia is not the electrolyte abnormality. Hypocalcemia is the electrolyte abnormality. Alkalination of the urine should not be done for all patients. It should be kept for the refractory cases because it may precipitate the precipitation of calcium phosphate in the alkalized urine and can cause obstruction. Calcium supplement should not be given to treat hypocalcemia. If not, it's severe, because if only severe, only low dose should be given. And rasburicase is contraindicated in G6PD deficiency. This is the true answer. So if we go by the tumor lysis syndrome, the phosphate increase, potassium increase, uric acid increase, calcium becomes hypo. So this is a very, very, very common question. And how does it happen? This is the flow chart. The xanthine is a nephrotoxic. So we use allopurinol, which inhibits xanthine oxidase. So the formation of xanthine is stopped or the formation of uric acid is stopped. But this is not good because xanthine is also nephrotoxic. So if the xanthine accumulate in the body, then it is also very bad. So the best option is to use rasburicase, but it is not widely available and it's also costly drug. So rasburicase are reserved for certain conditions. So it directly breaks down uric acid and converts into the allotonin. Allotonin is a harmless which is easily excreted through the urine. So, but the rasburicase is contraindicated in G6PD. So these are the lines from the standard books. The alkalizing the urine may reduce the uric acid precipitation, but the alkaline urine will promote the precipitation of calcium phosphate and xanthine. Uric acid can generally be controlled with rasburicase, so it's better to avoid alkalinization of the urine in tumor lysis syndrome. Rasburicase contraindication is G6PD deficiency. So you should remember G6PD deficiency is an contraindication for using of rasburicase, and it is indicated when the uric acid level is greater than 8 mg per dl. Indication of dialysis in tumor lysis syndrome is refractory volume overload, refractory hyperkalemia, uremia, symptomatic hypocalcemia, and calcium phosphate product is greater than 70 mg per dl square. Ignore hypocalcemia if possible. Do not treat asymptomatic hypocalcemia because this calcium may precipitate with phosphate, as the phosphate is very high in this condition and may lead to formation of renal stones. Therapeutic plasma exchange is indicated in which of the following condition of the poisoning? The answer is protein bound greater than 95%. Why this is? This is the chart which goes for the extracorporeal therapy of poisoning. So this is, you should remember that we should only go for the extracorporeal therapy if it is not endogenously cleared, if there is no antidote to treat that, if there is no absorption or adsorption by which the toxicity can be minimized, only in this condition we will be going for the extracorporeal therapy. Extracorporeal therapy matlab dialysis. By dialysis we will be eliminating the drug or the toxin. So when will we use what? So what percent of the poison is protein bound at the current concentration? So if it is greater than 95%, go directly to the therapeutic plasma exchange. If it is 80 to 90%, then it is hemoperfusion. If it is less than 80%, then only it will be removed by dialysis. Why? Because if it is more than 80%, then most of the drug or the toxin will be bound to protein and it will not be eliminated by the diffusion or osmosis process of dialysis. Because when it becomes bound to the protein, it becomes a large molecule and it is very difficult to come out through the, it becomes very difficult to make it come out through the extracorporeal therapy like dialysis, hemodialysis. So we need therapeutic plasma exchange in case of highly protein bound. So it can come as an option for therapeutic plasma exchange also, not in case of poisoning. Therapeutic plasma exchange is preferred for the drugs with high protein bound, low protein bound. Likewise, you can get option. So the answer will be highly protein bound drug where you have no option to exchange. You have to exchange the whole plasma. And the choice of plasma exchange are generally albumin. It is FFP only in case where some factors are missing, like in case of thrombotic purpura or TTP. Which of the following doesn't inhibit factor 10A? Remember one algorithm. If it doesn't contain 10A in the name, then it will not inhibit 10A. You see in apixaban, it is XA. In rivaroxaban, it is XA is there. In fondaparinux, 10X is there. But in dabigatran, there is no question of X, only DBGATRAN. But one thing remember, at the end of the dabigatran, you get tran. So what is tran? TR for thrombin, AN is the antagonist. So dabigatran mein tran is thrombin antagonist. By this you can remember argatroban, also tran, it is thrombin antagonist. What is thrombin? It is factor 2. So the factor thrombin antagonist are dabigatran or argatroban. And what is 10A antagonist? Apixaban, rivaroxaban, fondaparinux. If X is in the name, then only it is XA inhibitor. If X is not in the name, then it is generally not an XA inhibitor. Maybe some exception come in future, but for now you should remember like this. Answer is dabigatran. Inverted Martini class state is found in, these are the naming questions. You may have one or two in your exam. It is found in the fibrinolysis. So you must remember this R time, K time, alpha angle. As the time has already exceeded, I am going fast. So these are the names: brandy tumbler, red wine glass, test tube, camphor flute, and upside down martini glass. When what to use, you should be remember one or two type. This type of tricky question may come in exam. May not they be, they will give prolonged R time, decreased maximum amplitude, decreased alpha angle. Instead, they will be giving these names. So try to remember these names for your exams: brandy tumbler, red wine glass, test tube, champagne flute, and upside down martini glass. Resting tremor, there are 4-5 questions for the medicine, because medicine has come during this Neet SS 2024 also. So you should be reading little bit of medicine for this. Not little bit, critical care is all about medicine, but the core medicine which we do not deal normally, we have to know 1, 2, 3 knowledge about this. Resting tremor which increases on action is the rubral tremor. You should be remembering this classification. This is the screenshot from my MD PG preparation days of medicine note by Dr. Thamim. So tremor present at rest, decreased while in action is Parkinsonism, increased while in action is rubral tremor. Tremor not at rest but started on action is the intention tremor, cerebellar. Postural tremor is the essential tremor, which is minimal at rest and increases more on action, is the essential tremor. So these are the classification you should remember for tremor. Slow distal snake line wriggling movement. These are all classical medicine question. The answer is athetosis. This is the classification of the dyskinesia. If there is a repeating movement, then it is tremor. It is non-repeating involuntary movement, then this classification comes slow and rapid. If it's a voluntary, we very commonly get in the ICU is the tics. This is the classical CT I gave you because this patient came in our hospital, not this CT. This classical patient came in our hospital the day before I was setting the question. And this was very commonly, this classical sign is the hummingbird sign. This is, so the answer, identify the disease, is the progressive supranuclear palsy. So what are these? These are the atypical Parkinsonism, which is the progressive supranuclear palsy or the multiple system atrophy. So these are the few things you should be knowing about the progressive supranuclear palsy. I have read this before my Neet SS exam. We are not very thorough of this because these cases are not very frequent to our ICU. But hummingbird sign, you cannot make mistake in your exam. Midbrain atrophy, hummingbird sign, hot crossed bun sign. This is the MRI or the CT you can get in the exam. This is a multiple system atrophy. Remember these signs at least if you are not remembering the whole disease, because most of us from the anesthesia background feels difficult to go by this core medicine. I agree with you, but remember these sign names. Go back, search in the Google, see one or two CT or MRI. You may get these questions, and these questions, getting this question right may fetch you good rank in exam also. This is also typically a question I got when I was in the first year in the critical care. So this is the example of a dermatomyositis. So the answer was dermatomyositis. What are those signs? This is the typical heliotrope rash. This is the typical shawl sign. This is the Gottron's pupil, and this is the calcinosis cutis. So we have no time to discuss all this in details. We can discuss in personal message. And in our close group, I will advise you people to join our close group in as much as possible. Who have not joined, who have already joined, I am sure they are getting benefit every day. So my last 3-4 questions, I will be going very quick. Hemoglobin low, serum iron low. Till then, that it may be iron deficiency or it may be chronic anemia of chronic disease. But we have to look in the ferritin. For calling it an iron deficiency anemia, ferritin should be low. If the ferritin is normal with a low serum iron, then the answer is anemia of chronic disease. This is how you differentiate between iron deficiency and the anemia of chronic disease. The differentiation comes in the ferritin. This question was asked to me by giving a lab value in the DRNB practical final exam by the examiner. And this is a very conceptual thing that the ferritin is high or normal in the anemia of chronic disease. In iron deficiency, the ferritin is low. Iron is low in both cases. Transferrin saturation is low in both cases. But TIBC, remember in iron deficiency, there is a true iron deficiency. So the TIBC goes up. But in anemia of chronic disease, there is decreased production of transferrin. So the TIBC may become normal or become low. So TIBC up, iron down, ferritin down, iron deficiency. Ferritin up, iron down, and TIBC normal or down, anemia of chronic disease. So these charts you should remember and memorize for your exam. These are the potential MCQs. Coming to the Stewart approach, which of the following is independent variable in ABG according to the Stewart approach, except remember the tagline of Stewart approach. When we in our DRNB or DM course read Stewart approach, which is a very interesting approach in the ABG, to me it's one of the easiest approach to solve an ABG. If you are reading this Stewart approach, the finest line I have read before entering into the Stewart approach, park the car of bicarbonate in the parking and enter into the room of steward. So if you are entering into the room of steward for reading steward approach, park the car of bicarbonate in the parking. That means bicarbonate has nothing to do in the steward approach. So the independent variable in ABG according to the steward approach are all except bicarbonate. Bicarbonate is not an independent variable. You don't need to calculate bicarbonate in Stewart approach. So the Stewart approach, bicarbonate is out of the room of the Stewart approach. So the answer is the bicarbonate to the question number 37. We are not going, remember this theoretical thing, Stewart approach rely on the laws of conservation of mass action, electroneutrality. The independent variable are total CO2, strong ion, and total acid or A tot. We will be giving questions in the subsequent exam from this slide. So be prepared for this slide. Stewart approach independent variables are CO2, strong anion difference, and A total or total weak acid. What is HH? Hindenburg-Hasselbalch equation. Here the independent variables are CO2 and bicarb. So in Stewart approach, bicarb is not there. For Stewart approach, park the car of bicarb outside the room and enters into the room of Stewart. Remember this line for your whole life. So this is the most important concept of Stewart. Once you start reading Stewart approach, do not ever utter the word of bicarbonate in the Stewart approach. So this is the SID. We are not going into this. This is the classical scenario. C ANCA positive hemoptysis with AKI. We go in suspicion of recurrent sinusitis. So in the upper tract infection, lower tract infection, lower tract symptoms, upper tract symptoms with a kidney involvement, C ANCA positive. The answer is granulomatous with polyangiitis. The better name is Wegener's granulomatosis. So this was the picture given in the clue for the exam. There is a nodule in the there is a cavitation and a nodule in the CT scan. There is a sinusitis of the mastoid involvement in the CT of the PNS. There is a strawberry gingivia. This is a one of the most common presentation of Wegener granulomatosis in the ICU. So you get the C ANCA, P ANCA. Remember, C ANCA is for Wegener's granulomatosis. Remember as World Cup. So W and C. W is for C. And P ANCA is microscopic polyangiitis and Churg-Strauss syndrome. If you get a diffuse alveolar hemorrhage, your mind will go with the P ANCA positive. It will go towards the microscopic polyangiitis. If it is IgE positive patient coming with a history of asthma and the patient is getting this type of symptoms with the kidney involvement and the lung involvement, then your mind will go in the direction of Churg-Strauss syndrome. So Wegener granulomatosis is C ANCA, P ANCA is microscopic polyangiitis and Churg-Strauss syndrome. These are the classification of vasculitis. You can read by pausing the video at later time. For Bartter syndrome, decreased renin level is false. I will not discuss in details, but remember this syndrome, these are a potential source of MCQ. Bartter syndrome is like diuretics, loop diuretics. Gitelmans are like thiazide diuretics, and Liddle syndromes are like aldosterone antagonists. So there is Liddle syndrome is increased aldosterone function. So pseudo hypoaldosteronism is when the function gets decreased. So Gitelman syndrome and Bartter syndrome, these two are identical to the diuretics. The Bartter syndrome is like the loop diuretics. Gitelman syndrome is like the thiazide diuretics. So you need to read these in the details. We will be having more questions in the subsequent exams. This is the chart. You pause this chart during reading this video and read every line for your purpose, because this is a very potential source of MCQ and it comes again and again. We will discuss this in our closed group. We will discuss it in the subsequent tests also. Last question. Which of the following is not a mechanism of antimicrobial resistance in GNB? Target site, if altered, is a mechanism of resistance. Enzyme inactivation, everybody of you know, doesn't need any explanation. Amber classification, beta lactamase. Enzyme inactivation is a mechanism. Purine channel mutation. What are the purine channel? You see in this diagram. So these are the purine channels through which the beta lactams are entering. So if the purine channels are mutated, the drug cannot enter inside, so it cannot act. If the enzyme inactivation starts, so the drugs also cannot act. So the beta lactamase causes resistance to those drugs. If the target site is altered, it is also causing resistance to the drug. But what is efflux pump? Efflux pump puts the drug outside the cell. So if it is increasingly manifested, so the more and more drug are thrown out of the cell, it cannot act. So the efflux pump mutation or the increased activity of the efflux pump causes resistance to the drug, but decreased efflux pump activity doesn't causes resistance to the drug in GNB. So decreased efflux pump activity is not a mechanism for antimicrobial resistance in GNB. That finishes my part. I'm over time, so I will request Rashmi sir to go, and we will, if there are questions, we will be answering at the end of the session. And Rashmi sir, I will now stop sharing. You can start sharing your part.
Yes, Smriti, I am sharing.
If you have any question, kindly put in the chat box. At the end, we will have 10 to 15 minutes of discussion. We can answer those questions. And those who are in our close group, you know that we are answering the questions daily. So there is nothing to panic.
Am I audible and visible?
Yes, sir. You are audible, visible both.
Good evening. Dr. Prithviraj and Madam has already introduced the course. And one thing I want to tell, get the maximum benefit of this opportunity, which we are not aware during our entrance time and the preparation time. Coming to questions. Question number 1. For New Delhi metallo-beta-lactamase treatment options, answer is cholesterol. First, we have to look the Ambler classification. Ambler classification is classification of the beta-lactamase enzymes. It is class A, B, C, and D. Class A includes TEM, SHB, and CTX. And KPC. Class B includes BIM, IMP, NDM. Class C includes AMC. Class D includes OXA. Among the class A, we have to remember TEM, SHB, and CTX are the ESBL enzymes. And one important MCQ you can get, most common ESBL enzyme in India is CTXM15. Among these enzymes, KPC, OXA, and NDM are the carbapenem resistant. And the question was, which of the following treatment options is for the NDM? And the answer is cholesterol. We will make questions regarding these carbapenem enzymes in your next in our Telegram group. Coming to treatment for the Legionella pneumonia. Legionella pneumonia, Mycoplasma, and Chlamydia are all atypical organisms. What is atypical organism? These organisms lack the bacterial cell wall. And Legionella pneumonia is also called as the walking pneumonia because the symptoms are mild. So, as these organisms lack bacterial cell wall, beta-lactam antibiotics won't act. So the options will treatment options will be macrolides, fluoroquinolone, and doxycycline. So among the options, which is the treatment options except the treatment, the choice will be amoxicillin clavulanate. Which of the following is not an option for bloodstream infection caused by gram-positive cocci in the blood? Remember, among the options, all these options are the treatment of the gram-positive foci in the blood. But in ICU, if your microbiologist tell you that gram-positive foci is growing in the blood, you have to look for the MRSA organisms. Among the options, TG-cycline has high volume of distribution, so should be avoided in bacteremia. And TG-cycline is an option for the gram-negative organism as well as gram-positive organism. In carbapenem-resistant Acinetobacter infection, it can be used as a last option in bloodstream infection. Antibiotics having MRSA coverage are vancomycin, linezolid, ticoplanin, fosfomycin, TG-cycline, minocycline, trimethoprim, sulfamethoxazole, quinoproston, dapsopristin, and dalbavancin. Among these options, quinoproston, dalbavancin, and dalbavancin are not available in India. So the answer will be TG-cycline, which is not effective in the bacteremia, but can be used in skin soft tissue infection and intra-abdominal infection. TG-cycline should not be used in bloodstream infection, UTI. This was on previous year AIMS question. The term ARDS was coined by whom? And the answer is Asberg and colleagues. This type of questions you can get in the Neet SS examination. Which of the following maneuvers do not benefit a patient with ARDS? And answer is a little bit controversial, but the most probable answer will be muscle relaxant during the ventilation. Coming to positive outcomes in a case of the ARDS management, these are the trials. Coming to ProSaver trial, proning in ARDS patients in refractory hypoxemia leads to mortality benefit. Low tidal ventilation in ARDS patients lead to mortality benefit. That is the ARMA trial. Conservative fluid therapy in ARDS patients lead to better outcome in ARDS patients in terms of ventilator-free days, but not the mortality. That is the FACT trial. And muscle relaxant in ARDS patients lead to better ventilatory synchrony, but no benefit in terms of mortality or ventilator-free days. That is the rose petal trial. But the earlier trial, accuracy trial, leads to mortality benefit, which was counteracted by the rose petal trial. So the answer will be muscle relaxant during the mechanical ventilation. This is an advanced question. Murray score does not include. Murray score is used generally in the VB ECMO. This includes PaO2, FiO2, chest X-ray, PEEP, and compliance, not the plateau pressure. Score greater than 2.5 indicates severe ARDS and early initiation of venovenous ECMO. Another scoring system you can remember for the prediction of hospital mortality for the VB ECMO in respiratory failure is RACE score. Which of the following trials are not related to the role of steroids in septic shock? Trials you have to remember. There are some evidence you have to remember in critical care, and like the recent days in the Neet SS and the INICD, they are giving some evidence. Among the options are La SRS trial, which is not related to the steroid in septic shock. Coming to various trials of steroid in septic shock, these are the Anand et al., Corticos trial, Approaches trial, Apres trial, and Adrenal trial. Among them, Anand et al. And Approaches trial both use hydrocortisone plus fluorocortisone. Rest all uses only hydrocortisone during the septic shock. Among these trials, Anand et al. And Approaches trial found some mortality reduction, but Corticos Adrenal trial they have not found any mortality difference, but they have found that hydrocortisone therapy in septic shock reduces the vasopressor requirement and duration of the vasopressors. So the option will be La SRS trial, Meduri et al. Trial, and the DEXA ARDS trial. These are the trials for the steroid in ARDS treatment. We will go through these trials again in the Telegram group in the remaining days. Coming to the plasmic score, the plasmic score is used for re-stratification of which disease. This is a state short question. That is the thrombotic thrombocytopenic purpura. Plasmic score includes platelet count, evidence of hemolysis, no active cancer, no history of solid organ or stem cell transplant, means corpuscular volume less than 90, INR less than 1.5, and creatinine less than 2. The score 0 to 4 indicates low risk of severe Adams 13 deficiency of thrombotic thrombocytopenic purpura, score 5 intermediate risk, and score 6 to 7 of high risk of TTP. Coming to transpulmonary pressure, during long protective ventilation, transpulmonary pressure is estimated by P airway pressure minus P esophageal pressure. Actually, the transpulmonary pressure is the difference between alveolar pressure and pleural pressure. Esophageal pressure is the surrogate of pleural pressure, and clinical practice, airway occlusion pressure is surrogate of the alveolar pressure. Transpulmonary pressure is a alveolar distending pressure. In ARDS ventilation, it can be used as a surrogate to prevent ventilation-induced lung injury, which is variable during respiratory cycle, and it is used as a guide to end expiratory transpulmonary pressure should be less than 15 to 20 millimeter mercury, and tidal driving pressure should be below 10 to 12 millimeter mercury. And for a measurement of the intrapleural pressure, you have to use an esophageal catheter. So you have to be a little bit of invasive procedure. Coming to question number 10, hypothermia presents with all except. Hypothermia causes clouding of consciousness, muscle rigidity, diuresis, but it increases the QT interval. So hypothermia causes increasing in QT interval, which can lead to sudden cardiac death and sudden arrhythmia. So answer is state called shortening of the QT interval. These are the some
मिला
main.
है?
आप इतना परेशान कर दे रहे हैं हमको।
क्या परेशान क्या किए? नहीं मिल रहा था क्या? हाँ
कोई कहता है कि काम धेनु वीडियो अपार्टमेंट में थे हम
नहीं, हम तो बोल दिए थे आंटी को
नहीं, वो
ना।
काम धेनु तो काम धेनु दिखाई नहीं अपार्टमेंट इधर
ठीक है।
किधर बैस्केट किधर अमृतिया अपार्टमेंट मैं तो सब घुमा उधर
यहीं से आना है रोज, आप ही आएंगे क्या देने के लिए?
कौन आएगा फिर?
नहीं, वो अंकल आते हैं ना बहुत बार।
आए थे कल बार यहाँ नहीं आए
अभी नहीं आए। अगर आएंगे तो यही लिफ्ट से आइएगा, ठीक है? यही लिफ्ट से आना है, समझ गए ना?
उनका भी नंबर दो, मैं लॉकडाउन में सालों साल वहाँ रहा। कोई सुलोचन महादेव के थे, आकाश पांडे थे, मेरा साथ दिए, कोई बात नहीं, एक सेकंड सर, 1 सेकंड।
ठीक है, आप समझ गए ना? अब रोज यहीं से आना है, यहीं से आना है, और ये घर है, यहाँ पर नॉक करेंगे तो आ जाएंगे। हम खड़े थे, आपको मिलेगा नहीं उससे, ये वाला है, यही वाला।
Cupular sign is a radiographic finding of pneumoperitoneum, which indicates free air within the peritoneal cavity. It appears on supine abdominal X-ray as a gas trap underneath the central tendon of the diaphragm, giving it a cup-like or a saddlebag appearance overlying the lower thoracic vertical body. We can you can see this is the cupular sign. These are the name sign. So you have to remember during the preparation days. Placement of IBC filter should be done in all the following except patient requiring major surgery, diagnosed to have proximal DVT 1 week previously. A patient with malignancy who developed pulmonary embolism despite therapeutic anticoagulation. Patient with intracerebral hemorrhage who has DVT. And patient with having diagnosed of Aplar syndrome. The answer will be IBC filter should be used in case of the DVT in whom we cannot use the anticoagulation, or the anticoagulation have been failed, or there is recurrent chance of the DVT despite the therapeutic anticoagulation. So the option will be last option, patient with newly diagnosed antiphospholipid antibody syndrome, which develop DVT. In all the following conditions, anticoagulation cannot be stated due to the high risk of bleed, where therapeutic anticoagulation is not effective, or there is recurrent DVT despite anticoagulation, or complication of anticoagulation. So in this case, there will be the use of IVC filter. Coming to lab features of adrenal insufficiency are all except in adrenal insufficiency, there will be corticosteroid deficiency as well as mineralocorticosteroid deficiency. So there will be hyponatremia, hyperkalemia, hypoglycemia, and eosinophilia, not hypokalemia. The eosinophilia occurs due to the body's reduced ability to suppress the eosinophil production without adequate cortisol level. A 77-year-old male admitted to the ICU following triple vessel CABG. On day 3, he is hypotensive and oliguric with a BP of 75 by 50 mm mercury and a heart rate of 125 beats per minute. PA catheter shows PA pressure of 15 by 7 mm mercury, CVP of 3 mm mercury, PAOP of 5, pulmonary occlusion pressure of 5 mm mercury, cardiac index of 1.6 liter per minute per meter square, and SBR is 2750. Most likely diagnosis is. We have to rule out all the possible options. Coming to cardiogenic shock. In cardiogenic shock, this finding in the PA catheter is less likely. First of all, it is a day 3. The post-CABG cardiogenic shock generally occurs in POD 1 or 2. Still, in cardiogenic shock, there will be increase in POP and the CVP will also rise. Coming to cardiac tamponade. In cardiac tamponade, there will be equalization of the RB pressure, RA pressure, and PA diastolic pressure. In this case, this don't occur. Coming to sepsis, all these findings can be found in sepsis, but in sepsis, there will be vasodilatation. So systemic vascular resistance will be very low. Normal systemic vascular resistance is around 1800 to 2200. So in this case, the systemic vascular resistance is increased. So among all the options, the most probable answer will be hypovolemia. Next question. A 74-year-old female with history of ischemic heart disease and pulmonary edema has been admitted to ICU due to hypotension and presumed sepsis. She is currently on pressure support ventilation with a blood pressure of 80 by 40 and receiving minimal noradrenaline support. She presents with sinus tachycardia and her arterial blood gas ABG indicates a lactate level of 4.3 millimole of liter. What is the best guide of fluid resuscitation? We have to look all these options in the questions. First, the patient is in pressure support mode of ventilation. There is hypotension and noradrenaline support, and the lactate is high. All these signs indicate there is organ hypoperfusion and patient is in shock. So we have to look for the options. The option D, the pulse pressure variation will not be the option, because for pulse pressure variation, there should be complete paralysis of the patient, and the patient should be on a volume control mode of ventilation, and the tidal volume should be more than 8 ml per kg of the body weight. Coming to PA catheter insertion and POP measurement, these are the static measures of the fluid resuscitation. We have to look for the dynamic assessment of the fluid resuscitation. Coming to titrate fluid resuscitation against repeated blood lactate and measurements, this can be the option, but we have to look for the dynamic measure of fluid resuscitation. So the option will be PLR. We have to do PLR and look for the esophageal Doppler. In esophageal Doppler, we can look for the increase in the aortic blood flow, which will be the indirect measure of the increase in the cardiac output. So the options will be answer will be the option A, response to esophageal Doppler to PLR. Coming to our question number 16, a pulse oximeter measures the difference in absorption between two wavelengths of light to measure SpO2. The wavelengths are, the answer is straightforward, 660 nanometer and 940 nanometer. The red light absorbs the 660 nanometer and the near infrared light 940 nanometer. Oxygenated and deoxygenated hemoglobin absorbs these two wavelengths differently. The deoxygenated hemoglobin absorbs the red light more frequently, and the oxygenated hemoglobin absorbs the near infrared light better. Coming to question number 17. Regarding IBP, all are true except IBP can be used as a bridge to IBP is intra-aortic balloon pulsation therapy. It can be used as a bridge to transplant, bridge to destination, bridge to CABG, and bridge to revascularization. The contraindication of IBP are aortic dissection and aortic regurgitation, because in IBP there will be more chance of aortic regurgitation. Helium is used to inflate the balloon, not the oxygen. So answer will be the option C. And balloon is inflated during diastole and deflated during the systole. During balloon inflation in diastole, there is increase in the coronary perfusion pressure, and which will lead to increase in cardiac output in the cryogenic shock scenario. And the balloon deflates during the systole, which leads to decrease in the afterload, which will increase the cardiac output and cardiac condition in cryogenic shock patients. So the option will be option C. Oxygen is used to inflate the balloon. The appropriate answer is helium is used to inflate the balloon. This is little bit of tricky question. An ideal scoring system includes all except validity, feasible, applicable to specific population, and well calibrated. An ideal scoring system should be feasible, valid, should be generalized, not applicable to specific population. Well calibrated, it should have high discrimination, simple, rapid, and applicable to diverse population. So the option will be answer C, applicable to specific population. Rather, an ideal scoring system includes should be applicable to generalized. It is generalized, applicable to general population. MERS score. MERS score includes all except. MERS score, you have to remember, it includes creatinine, bilirubin, and iron, not albumin. Another score is MERS sodium. It additionally includes sodium. It tells about greater risk of death and more severe condition in chronic liver disease. It helps in liver transplantation prioritization. Higher the MERS score needs early liver transplantation. It is a prognosticate indicator. It is useful for monitoring disease progression and clinical decision making. So, higher the MERS score, it indicates that higher the severity of disease and high risk of death in CLD and liver cancer patients. This is also a little bit difficult question. About small for size graft in liver transplantation, false statement is. Small for size graft is defined as less than 0.8 graft to recipient body weight ratio, which may lead to small for size syndrome. This is absolutely true. There will be increased INR and there will be intractable ascites. But in small for size syndrome, there is liver synthesis dysfunction. So there will be decreased bile production, not increased bile production. So the answer will be increased bile production. Coming to acute graft versus host disease. Acute graft versus host disease affects all except it can affect skin, it can affect liver, it can affect GIT, but it does not affect the bone marrow. In the skin, there can be rashes, itching, and redness. Liver dysfunction can lead to jaundice and loss of appetite. In GIT, GIT symptoms like diarrhea, abdominal pain, and cramps. can happen, but it doesn't affect the bone marrow. Next question number 22. Regarding cardiorenal syndrome, all are true except. The answer is option 3. In type 1, we have to remember type 1 cardiorenal syndrome is acute heart failure leading to acute renal failure. Type 2 is chronic heart failure leading to chronic renal failure. Type 3 is acute renal failure leading to acute acute heart failure. And type 4 is CKD, chronic kidney injury leading to chronic heart failure. Type 5 is secondary, like in the autoimmune condition, sepsis, microcirculatory dysfunction, cytokine release. You have to remember this. Type 1 cardiorenal syndrome is acute heart failure leading to acute renal failure, which type 2 is chronic heart failure leading to chronic renal failure. Type 3 is renocardiac, acute renal failure leading to acute heart failure. And type 4 is chronic renocardiac, chronic renal failure lead to chronic heart failure. And type 5 is secondary, sepsis, autoimmune conditions, and cytokine release syndrome. All these comes in type 5 cardiorenal syndrome. This is a little bit of advanced questions you can get in the upcoming exam. Which point of care sonography protocol is used in cardiac arrest setting? Prithvi has already discussed it. This is the SESAM protocol. Radius protocol, false protocol, and Ross protocol. Radius protocol is rapid assessment of dyspnea using the POCOS by evaluating the heart, IVC, pleura, and lung parenchyma. False protocol is fluid administration limited by the lung sonography. You have to rule out the cardiac condition, pleural condition, DVT. SESAM protocol is designed for the cause of cardiac arrest. We have to look for the lung pathology, femoral vein for DVT and pulmonary embolism, abdomen and pleura for looking for the fluid and fluid in the pericardial fluid, pericardial effusion, pleural effusion, tamponade, and we have to look for the cardiac chambers, look for the cause of the cardiac arrest, either due to heart or anything else. Ross protocol is useful in the rapid ultrasonography in shock. We have to look for the pump, tank, and pipe. Pump is the cardiac contractility, tanks is the IVC, and pipe is the is your femoral vein and the circulatory chambers. So the answer is SESAM protocol. The trigger for developing posterior reversible encephalopathy syndrome. The answer is straightforward: acute hypotension. And the most common symptom of posterior reversible encephalopathy syndrome is altered sensorium, vision loss, and seizure. PRES is a reversible condition. It affects mostly the posterior distribution, the occipital, and rarely the parietal regions. Symptoms are mostly due to the vasogenic edema. Typically, it causes the visual disturbance, seizure, headache, and altered sensorium. And the most common risk factor is hypertension, eclampsia, preeclampsia, renal failure. Medications like cyclosporine, tacrolimus, anti-cancer drug, hyponatremia, and hypomagnesemia are also the risk factor for the PRES. The next question about organophosphorus poisoning. Most likely cause of abdominal pain in patients with organophosphorus poisoning. It is little bit of tricky questions. Mesenteric ischemia, acute pancreatitis, hepatitis, gallbladder calculi, all these can lead to abdominal pain. But in organophosphorus setting, you have to look for the acute pancreatitis. One of the rare manifestation of organophosphorus poisoning is acute pancreatitis, which can cause pain in the abdomen. It is due to excessive acetylcholine activity by blocking the choline esterase inhibitor, leading to increase in pancreatic blood pressure and leading to which can lead to acute pancreatitis. So we have to remember in organophosphorus poisoning, if the patient is having severe abdominal pain, we have to look for we have to rule out the acute pancreatitis. 9-year-old male presented with bloody diarrhea, abdominal pain, hemolytic anemia, thrombocytopenia, acute renal failure. E. coli 0104 S4 was identified in stool culture. Management includes all except all these scenario will lead to only diagnosis, that is the hemolytic uremic syndrome. And the treatment are fluid resuscitation, organ support, hemodialysis, nutrition, oxygen management, and if required, you have to go for plasma exchange. And plasma exchange is not very beneficial, but it can try in later stage in the hemolytic uremic syndrome. But antibiotics are not at all used, should not be used in hemolytic uremic syndrome because it can lead to release of toxins and can exaggerate the conditions. And the other option for the hemolytic uremic syndrome are the complement inhibitors, which can block the complement pathway, which is the cause of the blood vessel damage and the symptoms of the hemolytic uremic syndrome. So the answer is IV ciprofloxacin. Antibiotics should not be used in hemolytic uremic syndrome. Biomarkers of acute kidney injury include all except. The answer is interleukin 10. The tubular injury markers of the AKR, NGAL, KIM1, FABP, and NIG. Stress and repair markers are TAMP, tissue inhibitor metal proteinase 2, and IGF-BP7, and inflammatory markers are IL-18. So the answer will be the IL-10. You can remember these markers for your NEET SS examination, but this is little bit of difficult question. Raspberry is contraindicated in which condition? The answer is G6PD deficiency. Prithvi has already described about the raspberry in his slides. Raspberry is a recombinant form of urate oxidase. It is used to treat hyperuricemia following chemotherapy and is the treatment option for the rhabdomyolysis. In G6PD deficiency, it can cause severe hemolysis. So it should be avoided in the G6PD deficiency. Serotonin syndrome is characterized by all except altered mental status, autonomic hyperactivity. Linezolid can precipitate serotonin syndrome. Bromocriptine is the drug of choice. Bromocriptine is not the drug of choice for serotonin syndrome. Instead, it should be used in malignant hyperthermia. Altered mental status, autonomic hyperactivity, all these symptoms can be found in the serotonin syndrome. Various drugs can precipitate serotonin syndrome like monoamine oxidase inhibitor, serotonin reuptake inhibitor, tricyclic antidepressant, and opioids. Can cause altered mental status, autonomic hyperactivity, neuromuscular abnormality, delirium, hypertension, hyperthermia, muscle rigidity, tachycardia. Linezolid can precipitate serotonin syndrome. The treatment options are benzodiazepine to calm the patient. Cyproheptadine is a 5-HT antagonist. It can be used in serotonin syndrome. Beta blocker to treat the autonomic hyperactivity. So it can be used in the serotonin syndrome, not the bromocriptine. A 27-year-old female was transported to ICU from the ward with complaints of nausea, vomiting, and abdominal distension. She has been undergoing infertility treatment for 1 year, and 2 days ago she underwent an ovum pickup procedure. An ultrasound of the abdomen showed massive ascites and mild bilateral pleural effusion. What is the diagnosis? So the answer is straightforward: ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome can occur as a treatment of infertility as a part of pharmacological ovarian stimulation. These type of patients are little bit of tricky to diagnose, and the treatment options are rapid in the market. So these type of patients are coming to ICU nowadays. The answer is stop the ovarian stimulation drug and supportive treatment. Here there is leakage. Here there is leaky capillaries, and there is massive ascites, massive pleural effusion. So there is rise in the hematocrit. in a severe critical ovarian hyperstimulation syndrome, the hematocrit level can rise more than 0.55. You can go to the slide. So the answer is ovarian hyperstimulation syndrome in ARDS patients. High frequency oscillatory ventilation is generally frequently used in pediatrics and neonatal case, not in adult case. In this high frequency oscillatory ventilation, we use small tidal volume, 1 to 4 ml per kg, delivered in high frequency, that is 3 to 15 hertz, to maintain the constant long recruitment. Mean air pressure is generally increased due to constant long recruitment. Usually, the inspiratory time is prolonged, so there is less carbon dioxide removal. Among the evidence, the OSCAR trial and OSCILLATE trial, which had been used in ARDS patients, leads to no mortality benefit of the high frequency oscillatory HFOB. But these can be used in refractory hypoxemia patients, particularly infants and pediatric patients. So there is no mortality benefit in high frequency oscillatory ventilation in ARDS patients. So answer is option C. A, B, and D options are true. About ARNI, used in heart failure, which of the following is false? ARNI, GLP-1 analog, and SGLT inhibitors. All these are new medications, are frequently used in the cardiac patients. So we have to know a little bit of these drugs. And ARNI stands for angiotensin receptor neprilysin inhibitor, not nucleoside inhibitor. It contains sacubitril valsartan as combination product. Sacubitril is a prodrug that upon activation acts as a neprilysin inhibitors. Neprilysin inhibitors actually break down the natriuretic peptides. So the sacubitril acts as inhibitors of the neprilysin inhibitors. So there will be release of the natriuretic peptides, which will lead to helps in vasodilation effect as well as diuresis and remodeling of the cardiac musculature. Sacubitril in addition to valsartan. Valsartan is a angiotensin receptor blocker. So sacubitril valsartan is a wonder drug for the heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Answer is ARNI stands for the angiotensin receptor nucleoside inhibitor, not angiotensin receptor. Angiotensin receptor neprilysin inhibitor, not angiotensin receptor nucleoside inhibitor. Coming to next question, which of the following is false about fondaparinux? Fondaparinux is an anticoagulant. It is a synthetic polysaccharide. It inactivates factor 10A. It has less chance of heparin-induced thrombocytopenia. It can cause heparin-induced thrombocytopenia like heparin and the low molecular heparin. Prophylactic dose is weight-based. No, the therapeutic dose is weight-based. Prophylactic dose is standard. The prophylactic dose is 2.5 milligram OD. So the answer is option D. The therapeutic dose is weight-based, less than 50 kg. The treatment is 5 mg subcut OD. 50 to 100 kg, treatment option is 7.5 mg subcut OD. More than 100 kg, the option is 10 milligram subcut OD. And the prophylactic dose is fixed, 2.5 milligram subcut OD. Next question. Among the direct oral anticoagulant, which is a prodrug? It is very favorite question of NICT, Neet SS and AIMS. Answer is dabigatran. Dabigatran is a direct thrombin inhibitor. Rivaroxaban, apixaban, edoxaban are the factor 10A inhibitors. All these are direct acting oral anticoagulants. Dabigatran etoxylate, which is a orally administered prodrug of dabigatran. It is converted to dabigatran, which is the active form in the body. It is a direct thrombin inhibitor. So the answer is dabigatran. About antibiotic administration in sepsis, which of the following is false? Coming to option B, C, D, the initiation of antibiotic within 3 hours of possible sepsis, if concern of sepsis persists at that time. If the answer is true, as per the surviving sepsis guideline, if there is shock and the sepsis is probable or definite, we have to start antibiotic within 1 hour. If the patient is not in shock and there is probability of sepsis, we can look for the causes of the sepsis within the 3 hours. If there is still persistent favorite for the sepsis, we have to administer antibiotic within 3 hours. Option C, administer antibiotic within 1 hour of septic shock. The option is absolutely correct as per the surviving sepsis guideline. Recommended to use clinical evaluation alone for the antibiotic initiation. The answer is absolutely correct. Coming to answer option A, the mortality reduction associated with early antibiotic appears strongest in sepsis, irrespective of severity. The answer is mortality reduction associated with early antibiotic appears strongest in septic shock, not in sepsis. In septic shock, the early administration of antibiotic will lead to mortality reduction. And in each hour delay of the antibiotics leads to 7% increase in the mortality in septic shock patients. So the answer is option A. About steroids in sepsis, which of the following is true? These are the advanced questions. Recent evidence shows mortality benefits in steroids in sepsis. No. The recent trial, which is the adrenal trial, which showed no mortality benefit in steroid with septic shock. But there is decreased ventilator-free day vasopressor requirement in septic shock. Steroids should be given in septic shock after adequate fluid resuscitation and vasopressor therapy. If blood pressure is poorly responsive, the answer is correct. Recommended dose is more than 200 milligram if the patient is on high dose vasopressor. No, the recommended dose is 200 milligram of the hydrocortisone. Advised to use prophylactically in sepsis patients. No, the answer is it should be used in septic shock after adequate fluid resuscitation and vasopressor therapy if the blood pressure is not responsive. So the answer is option B. The steroid trials are the ananetal, corticos, approaches, hypres, and the most recent is adrenal trial, which is the recent trial. Recent trial, adrenal trial, showed no mortality benefit in septic shock, but less number of vasopressor free days and the ventilatory free days. About diabetes insipidus, which is false. High output of concentrated urine output of more than 250 ml per hour, serum sodium more than 150 millimole per liter, and urine osmolarity less than 200 milliosmol per liter. In diabetes insipidus, there is a decrease in the ADH, so there will be high output of the diluted urine, not concentrated urine. So answer is option A. There is excretion of the diluted urine, serum sodium more than 150, urine output more than 250 ml per hour, and urine osmolarity less than 200 milliosmol per liter. Ideally, the serum osmolarity is more than the urine osmolarity. So the answer is high output of the concentrated urine. Next question, for CBB SDF mode of the CRRT, what is the recommended dose of replacement fluid? The answer is straightforward, 25 ml per kg of hour. The answer is actually 20 to 25 ml per kg of hour. These are the advanced studies, renal study and ATN study. They found there is no benefit of the more intensive fluid removal in comparison to the less intensive fluid removal. that is the 40 ml per kg of hour of the replacement fluid remover in versus 25 ml per kg of hour per replacement fluid remover. So, in addition, the in more intensive fluid removal group, there was more hypotension. So, the ideal replacement, ideal recommended dose of the replacement fluid should be 20 ml, 25 ml of kg of hour. What is the indication of liver transplant in paracetamol poisoning? There is King's College criteria for the acetaminophen-induced acute liver failure and non-acetaminophen-induced acute liver failure for the liver transplantation. You have to go through this. The arterial pH should be less than 7.3 after adequate fluid resuscitation, or all of the following, like the prothrombin type for INR more than 6.5, serum creatinine more than 3.4, grade 3 or 4, hepatic encephalopathy. In non-acetamin induced ALF, the INR should be more than 6.5 or any three of the following: non-A or non-B, viral hepatitis, long induced ALF, time from jaundice to encephalopathy like more than 7 days, age less than 10 years or more than 40 years, and INR more than 3.5, or bilirubin INR more than 3.5. These are the criteria for the liver transplantation in acute liver failure. So the option is pH of less than 7.3 after adequate resuscitation. You have to remember, after adequate fluid resuscitation. Metformin intoxication causes. Among the options, normal anionic gap metabolic acidosis, no. Metformin causes the high anionic gap metabolic acidosis. Metallic alkalosis, no. Metformin causes type B lactic acidosis. Type A lactic acidosis is due to oxygen demand supply mismatch. It occurs due to acute hypoxia, carbon monoxide poisoning, anemia, cryogenic shock, hemorrhagic shock, and septic shock. Type B lactic acidosis is due to impaired oxygen utilization. It can occur to either by the drugs like ethanol, methanol, metformin, antiretroviral therapy, acetaminophen, linezolid, as well as impaired clearance. For example, renal failure, liver failure, mitochondrial dysfunction. These are the causes of type B lactic acidosis. So among the options, the answer is type B lactic acidosis. Metformin causes type B lactic acidosis, not type A lactic acidosis or normal anionic metabolic acidosis. I am finished, ma'am.
Yeah, I have been listening to it all throughout. Okay. There is a little sound in the background because I'm in Mumbai and we have Ganpati here. But I hope all of y'all could gain some knowledge. If y'all have any comments on how we can improve, you can put it on the group or even unmute and tell us now. Apart from that, there was a question in the chat box where they asked about what is the distribution of the subjects, I mean the pattern. So how much weightage does each system carry?
As that there is no proper distribution in the questions in the NEET SS exam, so it can come from any part. So it may be, so apart from this core pulmo, gastro, cardio, nephro, then now new topics, ethics, brain death, all are equally important. There is no such distribution mentioned in the brochure at least.
Absolutely.
As the statistics, these are also, we are getting questions from the statistics as well.
So as I said, there is no distribution. Respiratory, cardiac, hemodynamic, and ventilation, they are the most vast topics. And it is very difficult to cover them. But yes, what I would say is there are scoring topics also. For instance, there is a very short obstetric critical care. You may get 1 or 2 questions, but you cannot go wrong there. Okay, so I would look at that way, and that is what I advise people. So usually 15 to 30% for respiratory, 15 for cardiac is definitely there. But we often give a lot of time to these two topics and ignore the other smaller ones. So I would say you should divide your time equally for the rest, apart from the four which Dr. Prithviraj mentioned. Give equal amount of time to the rest of the smaller topics also, because they are very scoring, like surgical critical care, oncological critical care, obstetric critical care, statistics basics, because all these will really get you those extra marks, which, because see, it's very difficult to cover the respiratory and mechanical ventilation. It is nearly very difficult to cover the whole cardiac and hemodynamics also. But rest of the topics you should know very well. So give equal time to all. Don't give like good bulk to your cardiac and respiratory and then forget the rest. There's rest smaller ones is what I want to say. Even trauma is a very scoring topic. Trauma airway is a very common question. Invariably, all these exams will have airway and trauma related questions. So this is another important thing.
Nutrition, ma'am. Nutrition also is very
Nutrition
important.
is also very short topic, but it is very scoring.
Scoring, yes.
Yes, one or two questions from that. So you should also target them. Don't try to imbalance yourself towards doing a lot of respiratory and cardiac and then forget the rest, is what I want to sum up. There is no clear division, but yes, other exams do have this division, like 30% is to cardiac and respiratory and the rest 70 is to the rest of the topics. Any other questions from all of you? I think we had good number of registrations for this mini test one, and we opened the window for a very long time to take the test. But henceforth, we will not open it for very long, because we are planning to also give you all some scoring. So if some people take the exam, like some people even took exam this morning. So it is very difficult for us to tabulate the score, like who did better or what is a top scoring system. You may have found the first mini test tough. I would also say it was tough because you all were totally zero prepared. Maybe we are going to maintain our question level the same, but I am sure by next second and third test, you all will have a good hold on the subject, and probably you may find it easier, though the level of questions would have not dropped. Right, Prithvi?
Yes.
Ma'am,
Yes.
I think there are questions in the chat box.
Yeah.
Are LB mentioned those topics anywhere? I mean, like physiology, pharmacology, statistics.
I don't think they've mentioned it, have they?
No, 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 no.
No.
Oh.
No here.
But there is a question every time from statistics, from pharmacology. You
Yes,
can't
ma'am.
say,
Yes.
you can't say that you didn't mention pharmacology and there will be no question on pharmacology. I mean, asking you what drug to not give in pregnant is a pharmacology question, but it also an obstetric question. So you can't say that. Okay.
And ma'am, statistics is very much in the syllabus, mainly in the NESs who are giving NESs. At least two topics are in the from the statistics. It's compulsory almost. Type 1 error, type 2 error, any graphs, what we are discussing in our closed group. This likelihood ratio was the question during NESS 2022. So at that time it was Hebrew for me, but they covered this type of topic.
I think during our time in AIMS as well as Neet SS, I think every time we get 2 or 3 statistics questions, ma'am. Every time.
So what has happened actually in the change of pattern is when, I mean, at least I gave exams, the ones who were setting papers were mainly from the broad specialty, because critical care was not really an individual specialty which was divided.
Exactly.
So there were people who are working in medicine and critical care, anesthesia and critical care, chest medicine and critical care. So the ones who were setting papers were these balance papers. Balance. So we used to get a lot of questions from anesthesia, from medicine, and probably 20-30% from critical care. And obviously there were no statistics questions. There were no study related, trial related questions.
Yes, ma'am.
But lately, last 4-5 years, because the field has developed to a very great extent in India, and there are a lot of qualified intensivists who have come out, now those people are setting the question papers. So now when they are sitting with the question paper, they are putting hardcore critical care topics, and they are also putting the trials, the latest trials, and trials basically which are like the sizzling hot trials. They are not like very small trials which make no significance or anything. About how much will be covered in this course, it is a full attempt to cover every aspect, and that is the reason why we are keeping the WhatsApp group also very active. I mean, really takes a lot of task to put 8-10 questions per day, answer to all the queries. I mean, I'm sure Dr. Prithviraj is not doing anything throughout the day except this. And I'm sure at the end of 2 months, his child and his wife will have a, probably ask him for a vacation.
Ah.
For that.
Yes, sir, Rashmi sir also, sir, ma'am, it's
Yeah,
very
yeah. Both of
uh,
you. I'm so sorry for
in,
not
it's
mentioning. So Dr. Rashmi and
involving,
Dr.
it's involving throughout the day to give 10 questions and to answer in front of them, especially there are 4-5 in the group. They were so well read. They have read about SPEN 2019 guideline also. Yesterday I gave question about nutrition. They are quoting the guidelines. So it was beyond my imagination that at their level they will be reading guidelines. So it's very tough to become a question setter.
So Dr. Rashmi and Dr. Prithviraj definitely are doing a lot. And believe me, they are replying even in the day hours when they are on duty. I mean, when they are on their work, I'm sure their seniors also must be upset, but they are doing their best to cover every topic. Now, now the second question I'm sure in many minds is, then what else do we read? It's very difficult to answer because 2 months you can't really read a lot. I can't say that you read this and you will surely clear. But yes, whatever topics they are putting, for instance, there is a question related to sepsis. Why not open up sepsis and read from one of the books or maybe one of the PDFs? You can ask them for reading related to, like, where can I cover rhabdomyolysis? So when there's a question on rhabdomyolysis, just open up rhabdomyolysis on PubMed, a good review article, and read it. Or maybe you can open it from O's. I would take O's as a standard book for you all now. Don't go for Rippe or Fink or bigger books. But O's is a very good, beautiful book. Maybe that book you can take it and read one chapter from that. So when they say sepsis, they ask something about sepsis, read sepsis for that day. So I'm sure by the end of 2 months, you will cover a lot. Okay, that is the only way I can suggest to read for this moment. So there will not be much missing out of the content, because that is what I think both of them are trying to balance. They are trying not to repeat the question and also not trying to repeat the topic as well. So you won't really have this fear of missing out on major stuff for sure. Okay, if you in fact feel that we have not covered any topic for as such, you can always let us know, because the books definitely you all have it. But I'm sure at the end of the whole thing, you all will, most of the topics will be covered. Okay, and that is their target. For instance, today, this time they covered one section. Next time there will be another sections which will be covered.
If you feel that any section is not get covered, that somebody pinned me about nutrition, somebody pinned me about CT scan and X-ray. So day after our target, we have, I and Sir has a chat over WhatsApp. Ki next day we will put question from that section only. So if you are having any confusion, if you are having any fear of missing a topic, we have 60 days. 60 days into 10 means 600 question, almost 600 question. And I can assure you that those 600 questions are fresh new topics. I look into SARs, I attempt SAR MCQ every day. Yeah, अभी रश्मि सर जब मैं क्वेश्चन डालते हैं तो I attempt those questions and see whether what is the answer, and if those topics are not get repeated in my topic. So we are very less chance that we will miss some topic. But if you think we are missing some topic, let us know. My number, Sad number, everybody's number is there's open in the WhatsApp. Ma'am number is also there. You can text anybody. We want MCQ from this part. We can we can make sure that you will get MCQs within 1 to 2 days.
Okay. So I think we'll conclude here if there are no more questions. Also, this was the introductory prize from Dr. Prithviraj and Dr. Rashmi. But from tomorrow onwards, after 9 a.m., the prices will go up and it will be 3,000 for this whole course, because based on the effort that they are putting in. So if any of you or your friends still want to register, they can do it tonight at the introductory price. Okay.
Who have
So
already registered for the whole course, there is, because there's 1-2 questions that we have to pay again. There is no requirement of paying again. Who have already subscribed the whole course
yeah.
is for till November. But who hasn't subscribed, for the new subscriber, the price will be higher from tomorrow 9 a.m. as ma'am said. Okay. Okay, ma'am.
So all the best to everyone. We'll just end. Thank
Thank
you. Good night.